So uterine fibroids, because of their predominantly benign nature and the risk of a cancer of the fibroid being extremely rare, the option of observation and doing no specific intervention is a common choice for the patient and the doctor to arrive at. Fibroids will often continue to grow over a woman's menstruating years, and it would be most appropriate to reevaluate the uterus, probably with subsequent ultrasounds periodically, maybe yearly, for instance, or if a woman were to develop new symptoms with known fibroids. But technically speaking, fibroids in and of themselves don't need to be treated unless they're causing significant adverse effects to the patient. So if we were to approach the fibroids in a medical management sort of way, trying to avoid surgery or maybe delay surgery, the options are somewhat limited, but we do find that there's some success in doing oral contraceptive pills in either cyclic or continuous fashion to reduce the duration and volume of bleeding. They may stabilize the fibroids and allow them to stop growing. Additionally, there are some medications that will cause the fibroids to shrink. There's a medication called Lupron, which is sometimes given to patients to decrease the amount of estrogen and progesterone that their ovaries are making. It works through the brain chemistry affecting the ovarian production of these hormones, and by doing that, you can cause decreased hormonal support for the fibroid, causing it to shrink and, in a lot of cases, stop bleeding if bleeding is the problem. The surgical approach really depends on a number of factors. First and foremost, the location and the size of the fibroids. Some fibroids are amenable to an approach that would involve no abdominal incisions, and it would be done through the vaginal approach, through the cervix and into the uterus with a camera called a hysteroscopy. Those fibroids tend to be fibroids that are smaller, maybe 2 centimeters or less in size, maybe smaller than a golf ball, and tend to be more visible in the uterine cavity. And those are generally removed via a process of visualizing with the scope and then using a blade to remove the fibroids in a piecemeal fashion, either with electricity or with mechanical energy. And once the fibroids are removed hysteroscopically, the patient is monitored for bleeding, and really that takes care of the problem if it's in a location that's amenable to the approach. If not, the fibroids are generally approached via a surgical option through the abdomen. Most often we do, at Oakdale, we do minimally invasive surgery. Depending on the size of the fibroids and the difficulty of the surgery, given the patient's previous surgical history or anatomy, it may be warranted to do a large abdominal open incision to remove fibroids, but most of the time we can do either a laparoscopic or robotic approach, utilizing small, less than a thumbnail sized laparoscopic incisions to be able to essentially create an incision in the muscle of the uterus overlying the fibroid, extracting the fibroid with cautery and energy techniques, surgical energy techniques, removing the fibroids aside in the abdomen essentially, and then repairing the muscle of the uterus with layers of absorbable suture, restoring the uterus back to its normal as possible pre-fibroid size and texture, and then subsequently extracting the fibroids from the abdomen. If we're working through small laparoscopic incisions, this extraction needs to be done in such a way that the pieces are able to be reduced in size and then removed via these small incisions to keep it in a minimally invasive approach to confer the benefits of minimally invasive surgery for patients, mainly quicker recovery, less blood loss, less complications, less risk of infection. Myomectomy is a good option for uterine fibroids, predominantly for women that are interested in preserving their fertility. There is probably the most common surgical procedure done for fibroids in the world is a hysterectomy still. And a lot of women that have fibroids are at a point in their life where they've completed their childbearing or they don't have any further desire to retain their uterus. And a more straightforward approach in most cases for removal of the fibroid, especially if they're deeply embedded in the muscle, is to remove the entire uterus and then extract the fibroids, obviously, along with the entire muscle of the uterus. In women that are younger, usually, and that are interested in preserving their childbearing potential, a uterine sparing procedure like a myomectomy will allow the fibroids to be removed, but then the uterus to be kept intact and preserved for subsequent childbearing once the patient recovers from the surgery. I would say for management of fibroids, myomectomy probably makes up about maybe 10% of the procedures. Maybe 1 in 10 women will have a myomectomy. But really it depends on what their problems are and what their goals are. I oftentimes will have women tell me that they want a myomectomy, and then maybe after we've had a chance to talk about it, evaluate their specific life situation, their age, whether or not they desire to have children. Hysterectomy in a lot of women seems like a better option, just because we know that it's generally a more straightforward procedure with less blood loss potential and less future complications, and obviously no chance of recurrence of the fibroids if you've removed the entire uterus. So really it comes down to counseling, a discussion between a patient and a doctor trying to determine the exact right approach for that patient's condition.